Thank you for joining our session today. This is called Transforming Older Adult Care Through Value-Based Care. I'm Susan Newton. I'm the Senior Director of Strategic Initiatives here at Lutheran Services in America. And this webinar is part of our Strength and Service series, which is focused on identifying and seizing opportunities in today's uncertain climate, all with the goal of helping move your organization forward. I'm pleased to introduce Kelly Keefe. She's the Chief Product Experience and Innovation Officer at Serviam. We are very, very thankful to Serviam for their continued partnership with our member network and the work they're doing to leverage expertise on our benefit. We will have time for Q&A at the end of the presentation, so please feel free to use the chat to enter your questions, or you can send them directly to me or Kim Roke. She will be monitoring the chat as well, and we'll make sure that your questions get addressed throughout. And I'm going to have one preemptive answer to a question we generally get, which is that yes, we will be sending the slides out in a bit of a summary email to everyone who's in attendance and everyone who registered but wasn't able to make it today. So we'll get those out to you probably tomorrow, along with a recording of the session. So now I'd like to turn it over to Kelly to give us an overview of Serviam. Kelly?
Thank you so much. I'd also like to introduce my co-hosts. I've got Alan Fairbanks, who's also from Serviam Care Network. He's the president of our Value-Based Care Alliance. But Alan is unique in that he is also an owner in Bickford Senior Living. So he's got that dual side experience and is going to speak to you both from president of our alliance as well as the experience being in the senior living business as an operator himself. So I'm going to kick things off just giving you a little bit of an overview about Serviam and what it is that we do. So we believe at Serviam, that there is a higher path for seniors. And we believe that the era of value-based care has arrived and that senior living in particular must lead the way. At Serviam, we are empowering senior living's move to value-based care. We're here to be that on-ramp of senior livings in the future and today. And our purpose, which is what everything boils down to, our purpose is to be in service to the transformation of how America cares for seniors. When we thought about how to do that, one of the first things that we understood was that we couldn't go it alone. We had to surround ourselves with people who were like-minded, who understood the business of senior living, and who also wanted to enlist change. So the first thing that we set out to do was to create a network. We went out and enlisted the help of multiple operators. We've got at this point probably over 700 communities. Actually, I need to update this slide. 37 different states, and we're taking care of well over 50,000 seniors across our entire network. So all of these operators that are part of our network have really come together to help inform our direction and have gotten us really to where we are today. So today what we're going to talk about is our services related to value-based care. So we believe that value-based care is really the concept that healthcare providers should get paid for keeping people healthy rather than the volume of services that they deliver. And when I think about this concept, it's interesting. I recently had the analogy of thinking about a gym. And can you imagine how different your experience with a gym or a fitness center would be if you paid based on, or if they got paid, let's say, based on the value that they provided to you? So if they were out there ensuring your outcomes and they got paid because you met your goals, whether that was maybe for me to lose weight or for Alan to gain strength, if they got paid based on that, imagine how different that engagement and that experience would be. That's what we're trying to do for senior living, is we're trying to enable senior living operators to give seniors the experience and meet the goals that they individually want, and then help senior living operators get reimbursed for that. So our goal is to help seniors maintain that highest possible level of wellness rather than waiting until they get sick to provide care. And as you guys know, that care is often more complex, more expensive, and it's a bigger drain on the healthcare system as a whole. So we believe there's 3 ways to approach this. First, through a proactive health model. Secondly, we're going to improve health outcomes for residents. And then again, third, we're going to improve those financial incentives for operators. So when we look at the system today, we know that what drives health outcomes is about 20% clinical care, and then the remainder is social and economic factors, health behaviors, and the physical environment. However, when we look at where we spend our healthcare dollars today, it's very disproportionate, right? We spend about 88% of our healthcare dollars on clinical care, and yet that's the least really of what drives health outcomes. And then we spend our money on, just a small fraction of those socioeconomic factors, those social determinants of health, that really are the things that drive health outcomes. And that, as a result, has created this hospital-centric sick care system, which has become really reactionary and episodic. It's fragmented, disconnected, and it creates dependency on the system. So we continue to go through the same cycles over and over again. And it's very expensive. You think about that, 88% of those healthcare dollars spent on this thing that doesn't really actually enlist that much change. Today, what we see, and I'd be curious to hear your feelings about this as well, feel free to throw them in the chat, is we feel like many seniors today, in spite of the best efforts of senior living providers, they're oftentimes on the lower path. So when we think about this graph of quality of life over time, and we measure success on health, dignity, independence, et cetera, what we see is that seniors often experience an event that introduces them to our communities, oftentimes a fall, right? So that fall happens, they were leading an independent life prior to that, and then their quality of life kind of dips down and it never really makes it back up. And around that time, that's usually when they enter, one of your communities, right? And then you bring them kind of back up to where they were, but they never quite make it all the way up. And then there's another event and another event, and another event. And then they have this downward spiral that leads to the end of their life. And that quality of life has diminished significantly over time. And at the same time, what we see is that healthcare spending in that time frame is very significant. It's about $800,000 on that lower path journey that the seniors are taking. What we believe is that we can actually introduce what we call the higher path. So we're not going to be able to stop every event from happening, but if we can get ahead of some of those events, maybe lessen the impact, lengthen the amount of time between events, introduce better ways to recover, to get back to where they were, what we can do is help seniors live a longer, happier, healthier, better quality of life. And then at the same time, when we look at healthcare spending, we have seen that we can produce a savings of about 10 to 30%. And that difference there is what we're tapping into to help reimburse you for that improved care and quality of life that we're giving seniors. So I'm going to toss it over to Alan to talk about his experience in doing this and what we're doing at Serviam to enroll other providers in this model.
All right. Thanks, Kelly. Appreciate that. So, when we think about this, we really believe senior living is a key stakeholder in this move to value-based care. And why do we think that? Multiple reasons, as we shared here, right? Senior living impacts all of the factors that drive health outcomes. When you think about us as operators, we have a known population, right? Those individuals live with us. So we impact and control things like their environment, their social behaviors, their health behaviors, the nutrition, the clinical component. All of those things are things that we control. So we have an impact on those things. In addition, we have a trusted advisor relationship, right? They're making a significant decision already to move into one of our communities, so they trust us. So that relationship that we have with them influences and impacts things like physician choice, pharmacy choice, health plan choice, health insurance choice. Those things we have the opportunity to influence. We also have, an exponential impact on healthcare spending. When you look at the overall healthcare spending in this country, 50 to 60% of that total healthcare spend is on 15% of the population, seniors. Where do a lot of those seniors live? They live in our communities. So if anyone is going to have an impact on the overall healthcare spending in this country, I believe it's our industry. It's the senior living industry, because we can directly impact that spending through the relationships that we have with those seniors. We are also a strategic source for both the development of a health plan benefit and also the sales of those health plans because of our trusted advisor relationship. So when you think about like what's the problem, and when you look at senior living communities and the potential for value-based care, it really, at the end of the day, it's a capacity issue, and it's a capacity problem, because there are a lot of gaps. There's a lot of capacity gaps, such as there's an educational gap. People in general, when you talk about value-based care, they don't necessarily understand the model, and they don't understand how to approach value-based care. There's an operational gap. It does require a different business model and a different care model. It's a proactive model that's required versus this reactive model. There's the relationship gap. They don't have the relationships with the key stakeholders, specifically the payers. There's technology gaps. There's technology gaps from the opportunity to be able to have a different technology solution as it relates to value-based care, and look and be able to understand the data to be able to truly impact value-based care. Scale and density, it takes a lot of scale and a lot of density to really have an opportunity to enter into value-based care in a meaningful way. And there's a lack of incentives. They're misaligned, and the financial model doesn't really exist as it relates to this incentives that are aligned with senior living communities. So where is that solution? Well, we feel the solution is it's in a platform that allows senior living communities to thrive within a value-based care system. That platform includes a holistic approach, an approach that's proactive versus reactive, one that improves outcomes as a whole. And for us, what we've begun to implement and do is create alliances that create scale and density. They align incentives, and we help to manage the network that it takes to operationalize value-based care. The overall higher path model of care that we've implemented and been exploring at Bickford for really the last 18 months, that we're now ready to introduce to the rest of communities, is this higher path model of care. This model of care includes these components. It includes a network, includes technology, includes data, a playbook, and interventions. So we'll unpack each of these a little bit as we go through. So first of all, you have the network. What is this? It's a high-performing network that includes providers and payers. It includes standards and service agreements. So when we look at this network, you have senior living sitting in the center, right? Whether that's skilled nursing in the center and assisted living on the outer ring, or whether that's assisted living in the center or skilled nursing in the outer ring. Really, when I think about the senior living industry, that's kind of interchangeable. So you have one of those components at the center, and then you have this group of primary providers. You have a group that is specific for home health, therapies, primary care, hospice, palliative, behavioral health, and then either skilled nursing or assisted living or that other senior living component. And then a group of secondary providers, which includes all of these others in this outer ring. But I think what's kind of most important when we think about this high-performing network is we need to think a little bit differently about this in a value-based care world than what we typically do. Because, I've been owner-operator for 30 plus years now, and the way we've always approached this performing network is about referrals, right? Who do we think can give us referrals? And let's go get in relationship with those people, and let's try to get 3 or 4 hospice organizations because we think we're going to get referrals. But in a value-based care, what's really, really important is we really need to go out and curate who are the best operators of these particular components in these markets. And that's who we need to be in a relationship with. Let's go find the best hospice palliative care provider that's going to understand the overall proactive nature of this and how do we want to proactively approach value-based care. Same with therapy, same with primary care, behavioral health, all of these other components. Let's not go out and just try to get in relationship with everybody that we think is going to give us referrals. Let's curate the most efficient network we can to drive the overall health outcomes and meet the needs of those individual residents from a holistic standpoint, not trying to gain referrals. So when we look at that next piece, that next phase in technology, what we're really bringing to the table is number one, outcome focused technologies that we've curated, and also an operating system to help operators really execute really well value-based care. The importance of that is this, right? It's all about how do we drive overall care, and it's not just about the clinical components. It's about all these other factors as well: the social and economic factors, the health behaviors, and the physical environment. We've curated some technologies like Safe4You that we've utilized in our Bickford communities. What we've seen since we've implemented Safe4You is we've reduced ER visits by 90%. Because we know what occurred. It's AI technology. We know what occurred with the fall. So we're not just opening a door and seeing a resident, on the ground and not knowing what occurred. So what do? You call the ER. With this technology, we know what occurred. We know exactly what happened. So we've significantly been able to reduce why that's so important. In a value-based care world, when we move into a risk type relationship, every ER visits, somewhere in the neighborhood of $10,000 to $12,000. So if you're reducing those are dollars that are flowing back into your pocket as an operator, again, because you're getting paid for the outcomes that you're producing. That's why this sort of technology is really important to begin to consider and think about. The other, components, and when we look at this is from an operating systems perspective, is we're building technology that's going to include all of these various components. We're looking at building this integrated health record. We're not recreating an EHR. We're just looking at building a integrated health record that sits kind of above all these other disparate things, so we can have one place to go look at. Here's the medications, here's the lab results, here's some physician notes of when their physician visits are. Same with PTOT speech. One place where families can go, where the clinicians can go, where residents can potentially go, and where we as operators can go. So we're building that integrated health record. We're building a community level population health platform as well. We're building an enrollment manager into this operating system, because health plan sales and selling the special needs plans is really important. So to build that into the system, I think, is important. We're going to be able to build and have technology that's going to support the network, because when you enter into this space, you're going to need to know whether that podiatrist is doing a good job or not, right? In a value-based care world, we're going to help support that by using data to understand, are they doing a good job in caring for those individuals or not? And then we'll be able to approach them and help educate them on some things that maybe they should be doing a little bit differently. So we're going to help manage the network. We look at data as well. So I think data is critical, and I think about how much further we'd be ahead as an industry, right? If we had data that we've agreed upon previously and could consistently, share amongst others. But for us, this is the typical scorecard and outcomes that we're looking at. This can be customized by an individual community, but the things that we're looking at are things like response times for call lights, falls with injury, hospital visits, ER visits, inpatient hospital admissions, move-outs, primary care adoption rates, and health plan enrollment. We're looking at this data at our communities every single week by our leadership team, by our clinicians, by our rehab. Everyone is sharing this data and is aware of this data every single week, and our technology supports that at the level of a community. A playbook, simply what we're really building and have developed is a playbook as to how to operationalize value-based care. It's a consistent, this is how you engage with your physician and your clinical team. This is how you do health plan sales. This is the technology used to support that. And we created a playbook that we provide to every single community of how to engage with a value-based care relationship. Probably when I think about the most impactful thing that we've done at Bickford, it's around the Higher Path Council meetings. So again, I've been doing this a long time, and as I began to explore this, what I realized is for the last 30 years, I've really been living in this reactive world, right? Someone would move into Bickford, something bad would happen. I'd bring in all these care and services to the individual, and then I'd pat myself on the back by saying, hey, look how awesome I am, right? I'm taking such great care of this individual. When the reality is, what if I would have lived in a more proactive world and could have been able to prevent and delay some of those things from ever happening to that person in the first place? This meeting in and of itself has really helped to transform that and move in that type of a direction. So it's a weekly 90-minute meeting. It's in person. It's at every one of our communities. It's an interdisciplinary group of care providers, and we operate this in our technology. So you have the leadership of the community, the primary care physician is a part of this. The rehab is a part of this. We bring in our fall huddle specialist as a part of this as well. All of these individuals participate in this meeting on a weekly basis in every one of our communities. So some of the things that we're looking at, again, is this sort of rhythm, this agenda that's created. We start quickly with celebrations. Then we have some headlines that occur within the community. We look at that data, right? Everyone's looking at this data every single week. It's right there in the technology, and everyone supports that. We have the fall huddle that occurs. So we have a fall huddle specialist that comes on and participates in this meeting. Then we have committed actions. Everyone is saying, these are the things I'm going to do. This is what's going to happen. And from a accountability standpoint, this has been transformational. You can imagine if you have a clinician, a physician is interacting with this, a nurse practitioner is interacting with this, and they're saying, these are the 3 things I'm going to do this week to keep this resident on the higher path. And then next week they come back and there's accountability, because if they didn't get those things done, you've got the director, you've got the marketing person, you've got the local clinician at that local community talking to that physician. Well, you said you were going to do these things. Why didn't you get those done, right? So you've got accountability that's built into the system to make sure things happen. And then we're also, spending the majority of the time in this meeting is spent talking about those 8 to 10 residents that are most at risk that week for hospitalizations, most at risk for going to the ER. Who do we need to be talking about this week to keep on the higher path? That's where that proactive nature comes in. And again, this has been transformational for us at Bickford, because we've never done something like this in the past, right? Sure, we had daily stand-ups and we had care plan meetings and those things, but we really didn't bring up and surface who are these residents this week that we need to be talking about that are really, really most at risk. So we talk about that for 45 minutes and talk about what do we do to keep these individuals on the higher path, out of the hospital, out of the ER. And then we conclude the meeting, we score the meeting, we rank the meeting, and it's all, again, saved in there. And then next week we come back and we have that same meeting with that same rhythm the very next week, same time, same date, every single week for that meeting. The interventions piece, again, it's been so critical for us, because again, as Kelly unpacked, right, you have this event that occurs, this fall that happened. Well, the reality is that fall didn't just happen in isolation. There were things that happened and occurred that led up to that fall. Some things here were examples that we said, maybe there was a loss of a spouse that caused some nutrition deficits. Maybe then they quit going out to their typical activities. So they changed their daily routine. They stayed in their apartment more. The apartment became cluttered. As you think about those things, What would happen if we were to get ahead of those things and prevent, again, this fall from happening by doing things like fall monitoring technology, helping to organize the apartment, setting up some activities, getting them out of the apartment, looking at their nutritional deficits and their meal consumption. If we were to do those things, we could have prevented that fall from ever happening in the first place. This type of meeting and conversation, that's what occurs. And then you get this result, right? You get residents living happier, healthier, longer. The experience we've had in the communities where we've launched this is specifically in Virginia. We've seen a reduction in falls. We've seen a reduction in ER visits in those communities, reductions in hospitalizations and rehospitalizations. And ultimately, we've seen an increase in length of stay, right? Because when you think about like value-based care, there is this economic, economics to it, right? Because you're getting paid. But ultimately, it's the resident that benefits from this because they're at the center. We're providing better, more proactive care for those residents. And there are so many other benefits beyond just the economics, things like an increase in length of stay, things like we've seen decreased turnover by our caregivers because of the consistency that we've seen in our residents and taking care of those residents. We've seen a significant decrease in the turnover at the overall nurse leadership level in an individual community. Prior to this and to this model, we were dealing with, in a 76 apartment building, we were chasing 20 doctors around trying to get orders, and it's like herding cats, right? Moving to this model to where we're promoting and getting in relationship with a physician practice group, that's significantly changed the game for our nurse leadership. We're getting, physician order sheets signed in 2 hours versus 2 months. Those sorts of things are occurring because of this shift in a model of care that we've implemented at Bickford Senior Living. So what are value-based care? What are the payment models and again, aligning resident outcomes? Really, to get the attention of payers, you can't do this alone. I can't do it at Bickford. I think it takes, a local network that produces superior outcomes. So our approach at Serviam is we are creating value-based care alliances in specific states. We've used Virginia as an example here. That's where we've launched our first alliance. That alliance will get in relationship with individual communities, which represents, again, 2,000 to 3,500 individuals. So you start to create scale and density in that manner. So when we think about then what that creates and what we want to be able to do at Serviam is, we want to be that on-ramp to value-based care. We want to help individual communities access value-based care. We do that through creating scale, creating density. We do that through helping to implement our health model, that higher path senior health model. And we do that by also providing and aligning economic incentives that will eventually evolve to an at-risk model. So that alliance in and of itself is an entity that gets in relationship with the payers. And then it's that alliance that eventually will go at risk. And then we will reimburse those individual communities for the results that they produce at that community level. So what we're really giving is the ability to access value-based care at a community level without contributing capital. And then we as an alliance will shield them from any downside risk from a Medicare perspective and share in that upside risk as we produce results. So we'll manage the network. We're going to create those contracts with the payers and with the providers. We're going to help, again, source, identify those outcome-focused technologies that will be, helpful in being predictive, helping get people, again, out of the ERs and out of the hospitals. We're going to provide that operating system that supports the model. And the other thing I think that's unique and a little bit different about what we will provide at Serviam is, there's a lot of people exploring and doing value-based care. What I see and what I experience is you enter into some contracts and it's like, well, good luck, hope it works out for you. What we're doing is we've got someone hired They're going to be working side by side with communities. In Virginia, there's a local person full-time with Serviam that's going to be helping to onboard communities into a model of care, helping support them, being with them step by step, teaching and training, and helping produce outcomes. I think that's vitally important, because otherwise you're kind of out there with a wing and a prayer, just hoping for the best. And when you got dollars at risk, I don't think you want to hope for the best. I think you want to make sure you're doing everything you can to get the outcomes that you need to be successful. What does Alliance members get? You know, they get access to that outcome-focused technology. I'm willing to pay, as an alliance, we are willing to pay for that technology at either no or reduced cost. So, you know, we're implementing Safely You in communities and covering that cost for 2 years, so individuals have the opportunity to access Safely You, see outcomes, and get paid for those outcomes. So willing to provide that at no reduced cost. We're not charging for any of the technology that you saw to run those higher path weekly council meetings. We're providing that. I mentioned that no cost implementation support. Someone's there on the ground helping support you, working with you side by side. That playbook to operate and operationalize value-based care and how to create that high-performing network, we provide that. You also will be able to get negotiating power and influence, because you're going to be a part of a network in a local area that's represented by 50 to 60 to 70 communities. So that's going to give us, you know, and give you negotiating power and influence. Ultimately, you're going to get improved resident outcomes, improved operational outcomes, and you're going to be able to have a significant differentiation amongst your competitors. And you ultimately are going to be able to share in the financial savings the model creates. And ultimately, you know, our purpose at Serviam, which Kelly unpacked, right, is to transform the way we care for seniors. One of the ways, in addition, that I see us being able to do this and to help kind of raise the tide for the industry, as we create these networks at Serviam, one of the things that we're passionate about is we're going to produce those results and make those results transparent, right? So if you're a member of the Alliance, you know, the fall rate, you know, how are you performing from a hospitalization standpoint? All of those, like the net promoter scores, all of those key indicators of success that ultimately families should be using when they choose where they want their loved one to live. We're going to publish that information and make that readily available, because, you know, I had someone ask, well, if I'm operating the same model as the competitor across the street, what's my competitive advantage? Well, the competitive advantage is the standpoint that you should be doing a better job than them, right? We need to be able to raise the tide for everyone, not just create this, you know, ecosystem where I want to keep this all secret and you know, it's about the resident and raising the tide and providing the best possible care that we can for the resident. So that, to me, should be transparent. All should be available for the consumer to consume, so they can make decisions based off that information, not, you know, who's got the best bistro in the market or something like that. So the way you can participate in a value-based care system without, again, needing your own capital, we can help with the relationships, and we can help with scale and also with density. How to join the network? You know, it's simply, we have again, individual contracts with the Alliance. We help to teach and operationalize the higher path senior health model. You get improved health outcomes in a financially driven market where you can share in those outcomes and get paid for the work that you're doing. So that's like our approach in what we're doing from a value-based care standpoint, and bringing, again, value to operators. That's what Serviam is all about. You know, value-based care is one opportunity for us to be able to do that. We've done things in the areas of pharmacies for operators. We have our own diagnostics lab that operators have an equity stake in. So, you know, I'm an operator at heart. I've been doing this a long time. So I'm here because I want to bring value to operators in any possible way I can. We have a contact center that we utilize, that many of our network members utilize as well. So Serviam is part of a much bigger ecosystem than just value-based care, but value-based care is certainly a key business line, business vertical for us that we're really focused on and passionate about bringing to multiple markets in the country.
And I'm glad you brought that up, Alan, because while we've talked significantly about Virginia today, because that is the first state that we are kicking off the alliance. So that's the first group that are really going to follow this higher path operating system guide. As you saw at the beginning, we do have members all across the country, and we are continuing to bring on additional members. There are some criteria, and there's no cost of admission, but we do ask that you are a purpose-driven organization, that what we're doing resonates with you, and that you eventually do plan to participate in one or more of the offerings that we have. So like Alan said, value-based care is really at the core of what we do. But we do have those other things that you can participate in, like pharmacy, like lab, like procurement services. And at minimum, we have what we call cohort groups, which is an opportunity for these members to network with each other at various levels. We have cohort groups for our executives. We've held groups for sales and marketing professionals, for clinical folks, for HR even. And that's a way for our members to be able to bounce ideas off of each other and kind of work with each other in a safe space. So if you are interested in joining, please reach out to any of us at Serviam. So we've got myself and Alan on the phone, as well as Rachel Keller. She is our director of sales and marketing. Any one of us can help you participate and become part of the network. So with that, I think we're ready to open it up for some questions. And I've been trying to follow the chat here as we've gone. I've seen there's been some good discussion there too as well. So thank you for that. Any questions?
Great. Yeah, let's let folks from the group see if they have any questions. If not, a couple of come to me via private message, and a few other text and other things, so I can get us started. But first, I'm just see if anyone on the team or a participant in the group has anything they'd like to get answered quickly. I know what I saw when we first checked in, Valentina, I don't know if you have a follow-up on this, but you said your interest was really in making sure that you could, improving the lives of older adults. So just wondering if you have a follow-up there, like how seniors would benefit from working with Serviam. So let me turn that maybe into a little bit of a question for Alan or Kelly. I think you had a great slide that showed kind of statistically, there were some decreases in falls, decreases in visits to the ER. And there certainly was a picture of a very wonderful, smiley person who obviously was continuing to live her life and thriving in the community. But I think one thing that always resonates is when we hear stories of individuals and how those individuals' lives may have improved. So to Valentina's point about really wanting to make sure that seniors are benefiting from this, do you have some great stories you can share with us of where these actions have really taken a great improvement in the lives of some older adults?
Yeah, absolutely. You bet. One of the stories that occurred was in one of our Virginia communities. We had an individual that moved in and began to really become very isolated in her apartment. Didn't come out of her apartment. Spent the majority of her day in her apartment, and that was noticed by a therapist. That's the individual that first kind of brought that to her attention again during this higher path council meeting, right? Which is the importance of this care coordination effort, because you've got a therapist bringing something to our attention that without that meeting may not have happened, probably wouldn't have occurred. So during that conversation about this resident, what we found out was that resident had recently lost their spouse, and that's why they were becoming isolated and depressed. So what the team decided to do was they knew there was another resident that had just lost their spouse that had experienced something very, very similar, right? So they connected those two residents together to just have conversations and begin to talk about that in a meaningful way. And what occurred as a result of those conversations and that connection was that resident began to come out of their apartment. They began to become engaged in, activities. And now that's an individual that actually goes and delivers mail around to every single resident. That's how active they become in the community. That probably wouldn't have happened as quickly and as fast as it did without, number one, that weekly council meeting, and number two, the team together talking about how do we best solve the situation today. And we did it through another resident, right? We didn't do it through other means. So that's just one, small example of many of how this weekly council meeting and this model of care significantly impacted a resident in real time in one of our communities.
Thank you.
I think that's a really great example. And, I think about one of the things that we saw during COVID, and I'm sure you guys all experienced this, was that, just 2 weeks of isolation, in an apartment where somebody's not really getting out. We saw residents experiencing enough muscle wasting that falls increased by 5 times, right? Mm-hmm. And so again, when we think about those leading indicators of things that we can do to get ahead of that type of event, I mean, they're just, it sounds so small, it sounds so easy, but without that communication, oftentimes you're missing that because you're just so busy in your day-to-day. And so then this is really giving this council meeting and the accountability associated with that really gives that 360 view of the resident that allows us to rally around and think of all those things that we might miss otherwise.
So thank you so much. And those questions lead us to a couple of more that have come through. And, so I'll rattle off 2 or 3 here, and then we'll go back and address them one-on-one. But so you're speaking about those care meetings or the higher path council. So, one question might be, how much time does that take? And does that end up putting an additional burden on folks who are already stretched pretty thin? So that's one thing we can come back to. And then just your example about the people facing social isolation and how that as a social determinant of health can really impact someone's overall well-being. Just a little bit of conversation from you all about some of those other connections to social determinants of health. Like when you talk about the screening of different providers, do you include social determinant of health providers in that? And would those be some of the connections that could be made? So let's start with those 2 questions.
I'll take the first one as it relates to time. So yeah, a 90 minute meeting every single week sounds like a lot. But what I can share with you is that as we've implemented that meeting across Bickford, every time we've implemented that meeting, the leadership team is grateful and thankful, because what happens is they get about 4 to 5 hours of their week back. Because you think about, you've got all the decision makers and everyone in the room talking about residents in a proactive manner, so they no longer have to go and chase the physician down the hall, chase the rehab, and get all these disparate people connected. They're all right there in the room. And specifically the nurse leadership in our communities, they were like, what took you so long? That's the kind of conversation that we've gotten from Bickford. So that 90-minute meeting every single week sounds like a lot, but it actually ends up saving a tremendous amount of time because of the coordination of care that takes place during that meeting, with everyone there connected and talking about residents right there and there, and not having to go and chase each other down throughout the week, because it's all done right there in that meeting. So specific to that meeting, it's been a game changer for us, just from a sheer time standpoint. It's added time back to the teams when they have this meeting.
Great, thank you.
Kelly, you want to touch a little bit just on kind of this, again, this vision, this roadmap as it relates to bringing in this data and this disparate data from these sources as it relates to social determinants of health and how we approach that?
Yeah, and we have a really big vision around that. So some of the data points that you saw are pretty, standard data points, right? A lot of those are lagging indicators. So those are things, we of course always want to track our ER visits and hospitalizations and falls, et cetera, et cetera. But the thing that we're really working on that's exciting is getting in front of that and looking at the leading indicators. So what are those factors and how do we pull them out of disparate systems? So you've got therapy documenting in their system. So as Alan pointed out, the one gal that you saw delivering the mail, it was her therapist actually that had a conversation about, her starting to feel isolated and brought that to the group. So there's documentation there. There's documentation in the physician's charting system. There's documentation that your caregivers are doing, et cetera, et cetera, et cetera. So we're working with all of these third parties to be able to bring that data together and then apply some of the really cool technology that exists today in AI and machine learning to be able to understand the sentiment behind that and to start to read that type of documentation so that we're not only relying on people having to bring that to the table, but also we can gain some insights from the documentation that's out there. So that's some pretty exciting cutting edge stuff. We're just at the start of that, but that's really our, big, hairy, audacious vision for what it is that we're going to be doing. And then through that effort, we also, and we've actually already started some of this, is be able to prioritize the list then of residents that you'll want to be talking about, which is another really exciting thing. So that way, we can leverage technology to bring those people to the table, and then also leverage technology to understand who we've not been talking about, because a lot of times that's just as important as who we are talking about. Did I answer that question?
Yeah, no, that was great. And that's a great insight. Sometimes who we're not talking about is the area where we'll likely be focusing next. So a couple more questions. Well, and this was just one that I noticed, so forgive me if I am going a direction that's not helpful to everyone else on the call, but it kind of hits on, Kelly, what you were just talking about, is that you, in those meetings, really talking about, you didn't say this was just my word, but kind of the watch list, who should we be looking towards? And so are you just pulling that in the absence of data? Are you just kind of pulling that through conversation, or do you have some specific factors that really, help you identify who those folks are?
Yeah. So again, today it's largely what I would call analog, right? So all the team members are bringing those observations to the table. The great news is that the way that the technology works is that could be entered at any point in time. It could even be entered from your phone. So, again, if I'm the physical therapist and I happen to be having a conversation and I found out that Mrs. Smith's dog, who she had to give to her sister when she moved in here, the dog had passed away. And that's something that, the physical therapist might be hearing about in conversation that, the caregiver didn't realize, right? So being able to bring that piece of information to the table, along with information that we are gleaning from technology even today. And so like you saw, for example, Bickford's using Care Predict. That gives us really great information about, response times and calls and things like that. We also can use, gait technology to understand if somebody's gait has been changing. So that's an example of a technology that might, something that might be brought to the table. So there's right now, kind of a combination of a lot of different ways that those conversations are had at that table. But the great thing about it is that the tool is accessible at any time. So it's not a matter of, waiting until you sit down on Thursday morning at 8:30 to have your meeting before you can actually bring that to the group. That's something that you can preload and be ready for that conversation on your meeting date.
That's such a great point. We've had some conversations in other collaboratives, like the Rural Aging Action Network and Coalition for Better Social Care, which I see some folks on the call are in those as well, where it's, talking about that assessment process, that the assessment is an important tool, but often it's the information that's learned not through the formal assessment process that really helps you understand where someone is and where support might be helpful. And, Kelly, really appreciate you pointing out again that the tool and the technology are exciting accessible at all times, because that's often where the important information is. And to be able to capture that in a systemic way, I think probably really does help create that list of folks who you want to be talking about and looking out for. We're almost at time. Are there any other questions out in the audience?
There was a question that I'll touch on that talked about just process to get started with the model, right? One, certainly you can reach out to Kelly or myself, and we'd be happy to kind of walk through in a more formalized way. But for me, first and foremost, it's the first kind of step in the process is to get in a really good relationship with primary care physician practice groups, because at the end of the day, that's where this really all kind of begins, right? It's in that physician relationship. And for us, the mind shift was about moving away from 15 to 20 doctors to really exploring, hey, who is the physician practice group that those residents should be in relationship with, that are going to come to the community in a proactive manner. Our physician practice group sees our residents on a monthly basis, right? So we're moving out of the sick care system. They're seeing them every single month. So they understand who those residents are. They know the advanced care planning needs of those residents. And when something occurs and someone from the community is calling that physician just saw that resident last month, versus maybe in a typical physician relationship, if they bring their own doctor that they've had for 20 years, that doctor hadn't seen them for 9 months, right? So what's that person going to say? Well, send them to the ER, because they don't know any better. They don't know the resident. So it really, in my mind, just kind of begins with that physician relationship with the community and getting in a really good in-sync partnership, because that's where it starts. And that's the first step, I would say, is to really begin to explore that and think about that at your community level, beyond just obviously give myself or give Kelly a call, and we'll kind of help walk through and guide that process. But that's the one tangible thing I would say as a takeaway is go back to your communities and look at that physician relationship. Is that physician in a value-based care relationship? Or are they a fee-for-service physician that simply gets paid for writing orders? So they come in, they grab your nurse, they start going around the community and start writing orders, right? That's what we got to get out of the system, is that type of a relationship.
Kelly, any final thoughts?
Now, again, I saw that you put our emails in the chat, so thank you for doing that. Please feel free to reach out, not only if you want to be a network member, but if you've got any questions, or you're laying awake at 3 o'clock in the morning tomorrow thinking about what we talked about, and wanted to ask another question, feel free to reach out to us. We're happy to do this. I'm so proud of what we're doing. I really think that we are truly transforming the way that America cares for seniors. And I want to thank all of you for participating today and listening to what we had to share. So thank you all very much. And thank you all for what you do as well. It's really important.
Well, thank you, Kelly and Alan, for joining us today. As Kim has said in the chat, we will definitely be sending up follow-up emails from Kim. We'll get that out to you with the materials from the webinar, including a link to the webinar recording and to the Serviam site, as well as the contact information for Kelly and Alan. Kelly, I really want to pause and thank you guys for having that big, hairy, audacious goal. One thing about the Lutheran Services in America member network is that we really do care for all in our communities, and we really do hope that we're creating the conditions and finding the things that enable the people to live their best and healthy lives in caring communities. So the fact that there's a group like Serviam out there working in that same vein, and using the technology that is becoming more and more robust today to really help members such as ours achieve those goals. We really, really appreciate your partnership as we all move forward. So with that, just thank everyone for joining us today, and we hope you'll join us on December 14th. We're having another Strength and Service webinar at 2 p.m. Eastern. And we're going to be joined by Dr. John DeLutio and also Dr. Stanley Carlson Thies. They're thought leaders in how faith-based work sits at the intersection of policy and politics. So you can register for this webinar for free on our website at lutheranservices.org under our Strength and Service webinars. And lastly, if you need a certificate of participation, please don't hesitate to contact Kim at KROQUE@lutheranservices.org. Thank you all very much for your time, and we look forward to seeing you on our next webinar.
Thank you.
Thank you.